First of all, thank you everyone for coming to today's webinar. Most importantly, I hope that all of you and those close to you are well and healthy and that you're coping as best you can in this difficult time. I want to welcome you to the seminar. It's our pleasure at Thriving Earth Exchange to host it. Thriving Earth Exchange, as probably a lot of you know, helps scientists and communities work together to do science that advances community priorities. We call this way of working community science. It's doing science in ways that are collaborative, that welcome all expertise, and that are designed to address local goals. We make a special effort to work with communities that haven't had as much opportunity to guide, participate in, or benefit from science. And for us, it's never about telling communities what they should do. It's always about asking them what they want to do and then marshaling the science to help them do it. Right now, a lot of communities want to do something about COVID-19. And so the question we faced in Thriving Earth Exchange is the same question I face as an individual, and maybe the same question some of you are grappling with. How can we be relevant right now? The answer, I think, is the same as it ever was, with apologies to David Byrne. It isn't just about our disciplinary expertise, it's about our skills as science learners and communicators, our connections to scientific resources and people, and our ability to work with and in communities. So first, your skills. You're excellent communicators and science learners. You can use that to learn the relevant science, to interpret data, to read graphs, to understand the literature, to find, adapt, and share key messages. We hope this seminar can help you with that by giving you some background, highlighting some of those key messages, and pointing out where to go for more information. Second, the connections. You may not be an epidemiologist or a public health expert, but chances are you know one, or at least you know someone who knows someone. You can use that kind of connection to explore the things that are important in your community. This seminar should help you do that. We're offering an extended Q&A so that you can ask about the things that are important where you live. And third, and maybe most important, you're people who know how to work in communities. You get that science has to be practiced with empathy, and you know how to contribute science in ways that support and advance community leadership. This seminar may not help you with that, you already get it, but it can help you use that skill to pay it forward. And that's my ask, actually. Take whatever you can get out of this seminar and pay it forward. Ask the people around you what questions they have and help them find, contextualize, and act on relevant information using what you learn here. Be an ally, the kind of ally who brings science, and the kind who brings science with compassion and respect. So with that, I'll introduce our speakers and thank them for all they've done to get ready for the seminar and all they've done more generally. Our first speaker will be Kacey Ernst. She's an epidemiologist at the University of Arizona. She'll be focusing on the epidemiological data and how to understand and interpret it. Second, Mary Hayden, a health and behavioral scientist at the University of Colorado and the National Center for Atmospheric Research, who's going to talk about the things we can do to slow the spread. John Balbus, a physician and public health researcher at the National Institute for Environmental Health Sciences, will be our third speaker, and he'll review the key public health messages and the data sources we can use and share. All three of them are extraordinary, not just for the science they do, but for the way they do that science. All three are exemplars of community science, even though they don't call it that. In fact, I know one of them well enough to know that community science is just the default way they work, and they don't even name it. Each of our speakers is going to present for 10 minutes, and then we'll open it up for questions. You can submit questions in the chat window, and you can submit them anytime during the hour. Melissa and Kelly are going to compile the questions along the way so that we can get started with Q&A at the bottom of the hour. And with that, I'm going to turn it over to our first speaker, Kacey Ernst.
Hi, thank you for having me here today. So I'm going to delve into the numbers that you're seeing in the news, media, et cetera, and try to give you a better understanding of how to interpret those numbers. So this is a platform built by Johns Hopkins, which you can see the link at the very bottom to be able to go and keep yourself updated with those numbers as time goes on. This is the global picture right now. As of 5 p.m. last night, we were up to 95,506 deaths and over 1.5 million cases globally. And you can see that the United States is topping the list in the number of confirmed cases at this point. Next slide, please. Within the United States, there's great heterogeneity in where we're seeing cases at this stage. The predominance of cases are, of course, being seen in New York City, and we've had 16,690 deaths as of 10 p.m. last night. That number is swiftly changing with each and every day. One of the things that's really important to think about these maps is that this is portraying case numbers, confirmed case numbers, and so it is not portraying rates, which would be accounting for the underlying population size that is in each of these geographies. The other thing that these case numbers don't portray is the great health disparities that seem to be becoming more and more pronounced as this pandemic is moving forward. There's evidence that African American communities are suffering disproportionately from COVID-19 disease. Next slide, please. So how do we actually get to these numbers? One of the issues is that the way we do case counting is quite variable. So early on in the pandemic, we had case counts that were not tracking as well with our testing practices. So there's great heterogeneity in the testing that is available, and the United States was actually relatively slow in their uptake of testing, which means that there's a great number of cases that are likely missed. So if you think about how a case actually gets confirmed, there is a pathway that people have to take. And essentially, somebody has to present with symptoms that allows them to get prompted to seek care, to seek medical care. Once they seek medical care, they have to be provided with a test. And after they've been tested, that test has to then be reported. And so when you have testing shortages, not only are you compounding and missing cases that may be mild or asymptomatic, which we have identified as being a problem with this pandemic, that people can be mild and asymptomatic and still be transmitting the disease, but you're also going to miss people who are symptomatic, who do have pneumonia or have other consequences of COVID-19 disease that are actually not going to be picked up by our system. And so if you look at some of the cross-country comparisons in the next slide, please, you can see that the model that was implemented in South Korea was that you had here on the side, this is the COVID-19 tests per 1,000 people per day. So you have a range from none to 0.8 tests per 1,000 people a day, which is actually quite a high level of testing. And you can see, for example, Italy, which we know has had an early sort of peak in the outbreak, started ramping up testing and exceeded sort of that test per 1,000 per day quite quickly over what was going on in South Korea, where they were doing tracking and testing. And this is because they had such a significant outbreak due to the lag in the physical distancing measures that they took. So they had already had accelerating case transmission that was occurring. If you look at the United States, which is in yellow, they're sort of in the middle, you can see that the level of the level of testing was really almost non-existent until sort of the middle of March. And we have certainly accelerated our testing, but there was sort of a concerning sort of peak, and then we decreased our testing per 1,000 people again somewhere in the past week. And so trying to understand, what's going on with the numbers really necessitates understanding just how many people are getting tested. And this is going to change over time. And you'll be able to follow this kind of data in our World in Data, which is a data source out of Oxford. You can also follow it with the COVID testing tracking project, which has updated daily the level of testing at the state level as well. Next slide, please. So one of the other numbers that gets discussed a lot are the case fatality rates. And so everybody wants to have a sort of single number. What is the case fatality rate for COVID-19? But unfortunately, it's not that simple. So the case fatality rate is the deaths in confirmed cases divided by the number of confirmed cases. So you can imagine that you are going to be missing individuals in both the top and bottom of this equation. And there is also biological reasons why the case fatality rate may differ by different populations. So for example, when you look at the table below, you can see that in Italy, the case fatality rate in those that are over 80, for example, is about 20 per 20%. Overall, it's 7.2%. And then if you look at the case fatality rate in China, it's about a third in the overall population at 2.3%, and is also slightly lower in the greater than 80%. And so there are multiple reasons for this. This is in part because of testing and detection. So if there are individuals who aren't getting put into that denominator of confirmed cases, that means that you are going to have a false higher case fatality rate, but there are also real reasons why the case fatality rate may be higher in some places. If you have an older age structure of a population, if you have more comorbidities, people who are more vulnerable, and in the case of Italy, if you have healthcare systems that have been completely overwhelmed, they had to make decisions in terms of who to treat, who to provide the scarce ventilators to, and provide aggressive treatment to, and they triaged based upon who they felt would have the best health outcomes. And so when you have an overwhelmed healthcare system, it will greatly influence that case fatality rate, with healthcare systems that are overwhelmed not being able to provide as robust a care for individuals who are ill. Next slide, please. So as you can see, the case fatality rate across countries has been variable, not just between countries, but over time. As I said, this issue with the overwhelmed hospital capacity is quite nicely illustrated with the case of Italy. So you can see over time, their case fatality rate actually increased significantly. And this was as the hospital capacity became greatly overwhelmed. They were unable to provide that robust care to the population, and had to triage and decide who was going to receive care, which is a really devastating consequence of what could happen if healthcare systems become overwhelmed. Next slide, please. So some of the caveats, of course, the term case infers that you have had laboratory testing. And it really, if you have restrictive testing, again, if you're only looking at severe cases, the case fatality rate is going to be increased. And if you start testing absolutely everybody, that means your denominator is going to be much bigger, and you're going to have a lower case fatality rate. So don't be surprised if you see some of these estimates changing somewhat over time. And so, also you have to take into account that there's a delay. As somebody becomes sick, they 2 to 8 weeks out, maybe when the ultimate outcome is determined, whether or not they have recovered or succumbed to the disease. So it's important to think about that case fatality rate is going to be determined by the hospitalized cases that are 2 to 8 weeks before that time period. And then, of course, there is the need to actually attribute COVID-19 to cases of death. I personally know someone who had a parent who died of symptoms strikingly similar to COVID-19, but did not get counted because they were unable to get tested. And so, this is very complicated by comorbid conditions, hospital and vital statistics documentation, the availability of testing, as well as any posthumous testing that could be conducted. Next slide, please. So a lot of people are also discussing what we need to do to flatten the curve. How do we ensure that we don't overwhelm our healthcare system? How can we keep those case fatality rates low, the transmission rates low? And there are a couple of things that we can sort of use as concepts to think this through. So the potential for transmission is often dictated by what we call the reproductive number. And you probably have heard this R naught or reproductive number term in the media. And what the reproductive number is it's comprised of 3 primary components. One is the probability of transmission given a contact. So if you're in contact with somebody who has who's infected with SARS-CoV-2, what's the probability that you will also get infected? The duration of infectiousness, so how long can that person transmit disease? And then the number of contacts that they have per unit time. So the more contacts somebody has when they are transmitting disease, the higher the rate of transmission will be. So one of the reasons that we do physical distancing is to reduce that number of contacts so that we can take that rate of transmission and really try to make it lower and flatter so that we don't overwhelm our healthcare system and so that we can have reduced transmission. And so that importance of physical distancing really can be nicely illustrated in that reproductive number. Next slide, please. So in summary, when you want to be trying to look at the data, when you're looking at that data, there are multiple things you need to take into consideration. Look at the testing rates. This is available in multiple sources, and you can see with the covidtracking.com that you can look at the state level testing rates per capita, the conditions for testing. So some places are testing more holistically across the board. Some are restricting it to only severe hospitalized cases. Or people who are healthcare workers on the front lines who have repeated exposures. The case definitions, probable versus confirmed. Are these actually lab confirmed cases or are they including a wider variety? Looking at the underlying demographic, medical and social vulnerabilities, the healthcare capacity, the density of urban areas, the normal contact patterns. So places like New York City where people are very crowded and there's a lot of public transportation that's quite crowded, such as subways. This can also change those contact patterns and lead to a higher reproductive number or transmission rate. So one thing that I would like to note is there is no absolute number. There is no this is the case fatality rate. There is no this is the reproductive number. It is all context specific. And then I'd like to give a shout out to my colleague, Dr. Kate Ellingson, who had prepared some of these slides for a different webinar. And now I'd like to pass the baton to Dr. Hayden, who is going to discuss how physical distancing can help us reduce our transmission and risk.
Great, thank you, Kacey, and thank you, Raj and Melissa, for inviting me to participate in this. What I'd like to do from my side is to present just some basic messages on what we can do to reduce our transmission rates. And so the first thing is physical distancing, the way forward. Next slide, please. So this is just the beginning for many regions of the country. Many of you may be in areas that are only starting to see this epidemic. It's beginning to take shape in different regions, but of course we know that New York City may be seeing a positive impact of this idea of physical distancing because we're seeing, and we've seen this now for a number of days, decreasing hospitalizations. We're going to see cases and deaths continuing to rise both globally and across the US. And really, this is just the normal epidemic trajectory of a pandemic. So we need to brace for these impacts that are coming, but what we don't need to do is despair. Next slide, please. So we need to stay strong. We can only fight this epidemic if we work together. And we all know that all of our lives have been upended everywhere across the entire country, but we need to persevere. And we can't stop this epidemic unless we physically distance ourselves from one another, period. Next slide, please. The family is a really important unit and it has to function as a single unit. Physical distancing may decrease contact with the larger community, but it increases the amount of time and the contact that we have with our family members. So if one person in the family puts himself or herself at risk, everyone in that family unit is at risk. So if you think about it as one quick outing, such as for a haircut, or if you're taking a trip to the store for something that you really don't need, this sets off a chain reaction and places everyone in your family at risk. You encounter everyone with whom your hairdresser has come into contact, and you bring that back to your family. So even a small social chain can get complex. You go to the hairdresser and you later stop by your neighbors for a quick cocktail. Your neighbor is now connected to the coffee shop where the hairdresser stopped on the way to work, and the barista's son's girlfriend who went grocery shopping that morning at a store where some workers have potentially tested positive for COVID-19, and on and on. So it's very important that we consider our family and this with the physical distancing. So next slide, please. We need to disconnect the physical, but not the social network. Physical distancing will work. I mean, it may not seem so immediately, but we have evidence from China, from South Korea, from Italy, and even New York City that it will work. In Colorado, our governor has asked everyone to wear a mask when in public. And I think it's really important to remember that this does not preclude physical distancing, but rather it's a measure to protect people from asymptomatic spreaders who may inadvertently be transmitting to others. We know that potentially up to 50% of people can transmit asymptomatically. So we're all wearing masks. And of course, there are different gradations of masks as well. Most of the masks that I see around town where I live in Colorado are homemade. And people are pretty much adhering to this. So it's great to see. But it's important to remember that this is not an and or. This is we need to wear the masks and we need to keep our distance. So we need to remember that without a vaccine or an effective treatment, physical distancing is really the only thing that will work, period. We know what's coming, and we mustn't become paralyzed by fear. We have to keep the course here. And knowing what to expect, we can remain resolute in maintaining our distance and ensuring that the information we pass along to our colleagues, to our family members, to our community, ensuring that that's factual. So in the next slide, what I want to show are some Mythbusters from the World Health Organization. And I think these are really critical. I put the website up here so that you can go take a look at it a little more closely because there are lots and lots of these Mythbusters. And I think they're very interesting. The first one, 5G mobile networks do not spread COVID-19. From the meteorological side, cold weather and snow cannot kill the coronavirus. The coronavirus can be transmitted in areas that have hot and humid climates. And as we all know, we have no idea as to the seasonality of this. We do not know whether we'll see a decline in the cases of COVID-19 with the coming warm months in the Northern Hemisphere. And this next one I think is really important because I've heard from so many people that their doctors through telemedicine have been using this as a test. And being able to hold your breath for 10 seconds or more without coughing or feeling discomfort does not mean that you're free from the coronavirus, COVID-19, or any other lung disease. And another one that people are particularly concerned about because there have been reports of dogs and cats that have been infected with COVID-19, but there is no evidence that companion animals or pets such as dogs and cats can transmit the coronavirus. It seems that they are getting it from their humans. So next slide, please. So I'd like to close by saying that we can model the wise choice. And in fact, it's incumbent upon us as scientists to do so, to take the data and to model to our community what we should be doing. And we need to do this as a family, as a community, and as a nation. So we are stronger alone together. And I just thought I would close with this little sidewalk chalk piece that I found. April distance brings May existence. So thank you. I'd like to turn it over to John Balbus now, who's going to talk about some of the government communication responses and resources for us. Thank you.
Now I'm unmuted. I'm not sure if folks could hear my praise for Mary's last slide, which I really liked, and my gratitude for you all being on the webinar today. Thanks, Mary, and thanks, everybody. I'm going to circle back to some of the points that Raj started with, answering this question of what can the geoscience community, what can those who are working in the Thriving Earth Exchange do to help be a positive force in this pandemic response that we're all in. And I'm going to hit on a lot of the themes that Raj touched on. So the first is to really stay up to date, keep yourself informed, and very importantly, those of you who are scientists to use that scientific judgment, that scientific discernment to help interpret not only the science that's available, that I'll tell you a little bit about where you can find some good resources, but also some of the things that you may hear on CNN or in journalists' stories about scientific studies, and you can bring your own discernment and the kind of information that Kacey and Mary shared with you today to help interpret that. The second thing is really what Mary was saying, to be a force of good in supporting the public health messages about the physical distancing, the wearing of masks not being a substitute, as Mary said, and and also real important to make this distinction between physical distancing and emotional and psychological distancing, that more than ever we need to be supporting each other, as Raj was saying, that the folks in this community, that's what you do, that's what you know how to do. So we need to be providing, breaking down the emotional distance even as we're increasing ever the physical distance. I think that the geoscience community has a role because of their understanding of some of the physical science in helping to share information about the environmental aspects of COVID, whether that is things like the behavior of aerosols when somebody is jogging by you, which has been something in the news, or whether these virus particles can persist on surfaces, or the questions about climate and weather and the seasonality, and whether having a super humid day is decreasing your risk of transmission. You have the ability to really understand the earth and atmospheric science side of that, and now after Kacey's talk, you can also become public health scientists as well, and put those two things together. And then lastly, just recognizing what it means to be a trusted source of information in your community, that you do hold a very special position, that you do need to use your discernment and help people have reasonable skepticism, but also understand when the messages, even if they're not based on the most rock solid science, are based on years of practice and caution and ways of protecting people. And really importantly, as a trusted source, to be a model yourself and to model the kinds of behaviors that we're asking people to demonstrate. So with that as kind of the outline, let me go to the first slide. And I just want to share with you some of the really central federal resources on COVID. There are two primary sites. If you go anywhere within HHS, you're going to see the first two. The latest public health information is on a dashboard page at the CDC there, coronavirus.gov. And then there is a summary of research information from NIH at the URL that you see there. For those of you who are inclined to dig into some of the primary scientific literature, the National Library of Medicine has created a special resource page of the latest papers coming out. It's if you were to Google lit COVID, you would find it there, and you see the full URL. And then I just became aware yesterday of a very cool compendium of data sets and computational resources. Again, for those of you who want to delve into the basic data and look at some of the dashboards and tools, and that's available at that URL there. I'm sure these slides will be shared with you, and at the end you'll have my email. Anybody who wants, I'm happy to send a copy of these slides. Can we advance to the next slide? I wanted to share a couple of other federal resources. There is, for those of you interested in the global picture, there's a great page, the Fogarty International Center, that pulls together a lot of different resources, the WHO tracker and COVID page, as well as other resources there. Again, that's a URL. I'm sorry, it's you can't memorize that one, but if you were to just Google Fogarty and coronavirus, that's where you would end up. The second is for those of you working in the communities and trying to work with municipal governments and protecting people, et cetera, I just wanted to alert you to some training materials that my institute, the National Institute of Environmental Health Sciences, has made available through our worker training program, which is a real resource for this country in times of disasters. This is a program that maintains a network around the world around the country of academic partners with labor unions to produce really top-notch occupational educational materials to protect the health of workers in disaster settings and in cleanup settings. So for those of you who may have that kind of a role, that's a really great resource for you there. And then the final one on that page is actually a public resource. So anybody is open to join a group that's sponsored by FEMA. It's called Geospatial Coordination Calls During Disasters. They meet once a week. And this is a it's a real gold mine of different private and public entities that are creating dashboards and using geospatial information to get really critical facts and information out to communities. So anybody who is, again, working with the local governments, if you don't already know about these calls, this is a really fabulous resource. Next slide, please. And then since this is the American Geophysical Union, and whoops, that doesn't look like my next slide. I wear the hat as the Health and Human Services lead for the Global Change Research Program. A lot of the questions that come up, they may not be the questions. I'm not sure what that slide is. There we go. Okay, now it's building out. I wanted to share some resources specifically related to the question of interactions between climate change, and infectious diseases, climate variability, and the modeling of infectious diseases, et cetera, that these are not resources specific to COVID, but if you are interested in educating yourself or having good tools to work with this question of how does our environment interact with infectious diseases, this is a set of resources for you. I think there's one more at the bottom too, if you build that out. And the first is a literature portal that we have at NIEHS, where you can search by country and look up, very specific infectious diseases or just infectious diseases in general and climate change, and get the last 11 years worth of literature. This is a curated database that we've created to help you find what you want and be able to answer questions like that. We have a set of educational materials. If any of you are involved with the schools and trying to help teachers figure out what to teach kids while they're stuck online, we have modules on climate and infectious diseases, especially vector-borne diseases there. The CDC's guidance is very helpful for local public health departments in looking at vulnerable populations. The next two are the most recent National Climate Assessment, and before that we did a full special report on climate change and health. The latter has probably the most robust chapter on infectious diseases, but there's also very good resources in the fourth National Climate Assessment. And then lastly, if you're not already aware of it, you probably are, but the US Climate Resilience Toolkit has a wealth of information, including in the health section, some really good informational materials on climate and infectious diseases and how communities can protect themselves. And I raise that also because we need to remember that as we hit the pollen season, the tornado season, the heat wave season, and we move into hurricane season, even though we're in the midst of a pandemic, these climate and health urgencies and extremes are going to be affecting health both very much in terms of the COVID response, but also just in general. So these are resources to help communities deal with, just if they're unfortunate enough to have to deal with more than one threat at a time. So with that, I'll go to the last slide, which is just my contact info, and you can build that out. There we go. Happy to take it, looking forward to the questions, but also happy to hear from anybody offline if you have further questions. Thanks a lot, and I'll turn it back to Raj.
Thank you very much. I'm going to invite all three of you, Dr. Ernst, Dr. Hayden, and Dr. Balbus, back on. And we have the opportunity to answer some questions. They've been coming in through the chat. Please keep the questions coming. Melissa, I think you're curating the questions, so if you want to tee up our first question. Also, thank you to Melissa Goodwin and Kelly McCarthy for helping organize and doing all of the behind-the-scene work that nobody's seen to make this happen. Melissa, do you want to queue up our first question, please?
Absolutely. Thanks, Raj. So the first question that we have is, how does case fatality rate compare for COVID-19 and influenza? Apparently this is a key topic in some parts of the country. One community in Colorado in particularly, where some say it's not worse than flu, and local cases are currently low because of low testing and a great local public health infrastructure.
So yeah, I can take that. So yes, it is hard to get a solid number on case fatality rate, but all estimates point to a case fatality rate of COVID-19 being about 10 times greater than influenza at this stage. So some of the case fatality rates that have been put out for influenza are subject to the same biases that you have with the COVID-19 in terms of underreporting, undertesting. And when people have gone back and really tried to do more comparisons between the two using very comparable data, which is absolutely what you have to do, you have to make sure that the percent capture of cases is equivalent before you can start determining sort of what the level of the case fatality rate actually is. And most of those are sort of settling on about a 10-fold greater case fatality rate for COVID-19 as compared to influenza. So I guess the other part of your question, the other part of the question was about the community response. And absolutely, you know, I think public health becomes a victim of its own success sometimes, where, you know, when we do execute these sort of physical distancing measures, people are wearing masks, people are washing their hands more, you do actually start to see a real decline in transmission. And that means that you won't see as many cases because what we're doing is actually working. And so if we had just let this go without anybody, you know, washing their hands, doing physical distancing, closing schools, et cetera, we would be in a much more challenging position than we are right now.
One of the other questions that came in, I think kind of builds on some of the things you talked about, Mary. Are there metrics that we should be considering about when we end physical distancing?
Well, Raj, as you know, that's a huge debate within the federal government right now about when we should reopen. And I think that until we have that antibody testing widely available, I don't think that we're going to be able to justify reopening without having to worry about a complete resurgence in the number of cases and then having to shut down again.
Thanks.
I don't know, Kacey or John may have more to add to that.
Yeah, I have nothing to add to that.
So I would also add not just the antibody testing, but also testing for virus and ensuring that everybody who is symptomatic, even mildly symptomatic, can get tested. If you can really ramp up that testing, you have the potential, not guaranteed, but the potential for being able to do more contact tracing and specific isolation of people who have been exposed. And that is a more tailored response for the physical distancing that was executed in places like South Korea to great success. But at this stage, because we have widespread community transmission, that's not currently tenable.
Got it. That actually opens up the door to another question. One of the questions was about the availability of testing and if whether the testing components are becoming more or less not as available as we move forward.
I guess that's me again. So so it is becoming more available. There are commercial labs who are coming on board. There are drive-through testing centers that are coming in different communities. But the challenge is that it's not homogeneous, right? So you have some places where testing is actually becoming fairly widely available, and you have other geographic locations where testing is still rather limited. So it really depends on where you are. It depends on what sort of level of care you're going to. You know, I'm still hearing stories of people who go and who have a cough and fever and are being turned away for testing, even though they do show signs and symptoms of disease. But it is getting better, and there are certainly significant efforts underway to continue to scale up testing.
Great. A couple of questions have come in related to transmission. And I guess the question is about person-to-person transmission versus transmission from infected surfaces. One of the questioners points out that there's a lot of different information out there on that, and I guess they're asking for some help making sense of all of that.
Okay, I can take that one too. So in terms of the transmission, certainly, of course, there's transmission person to person. We know that that's quite clear. The transmission from fomites, I think, is still up in the air. There's of course been the study that indicates that you can have viable virus that can survive on surfaces for up to 3 days, depending upon the surface. And so the actual role, however, that is playing in determining whether or not people are getting sick or exposed is still somewhat unclear. The minimum infectious dose that's required for COVID-19 disease or for SARS-CoV-2 infection is not, I think, firmed down yet. And it's also just extremely difficult to really be able to disaggregate, okay, this person got infected from contacting a fomate, this person got infected by being in close proximity to people, because a lot of times those go hand in hand, so that you're in, you're touching fomites, or you may be in a grocery store and somebody is sick and doesn't have a mask. It's a really tricky, it's an excellent question. I think we would all really want to know that question, the answer to that question, but at this stage, it's still somewhat uncertain. And the main thing that we know is that it can survive on surfaces. And so disinfecting high touch points like door handles and faucets on sinks, et cetera, on a really frequent basis, they're suggesting about 3 times per day to try and reduce any potential transmission, even within your own household. If you have somebody sick, is sort of the current recommendation.
So I'll just add on a little bit to that. And Mary, did you want to?
Oh, that's okay. Go ahead, John. I'll wait.
I'm sure you'll have more after. I'm sure I will not hit what you were going to say. The first is that it kind of gets back to the point I was making a little inarticulately, where we have to make decisions. We have to give guidance in the absence of perfect information. I think we know that the transmission is occurring by multiple routes. We may not be able to quantify how much is coming from which route, but we know that there is transmission that is not just aerosolized inhalation. We know that it is being spread by fomites. And so that's where, Mary, your example came in, where one person goes out of the house and comes in. That's not necessarily all person to person. It's touching surfaces. It's bringing in those ways. So on the one hand, I think the precautions are not just about distancing and wearing masks, but also assiduous hand washing, as Kacey said, cleaning frequently touched surfaces, if anybody's coming in and out of the house, that kind of thing. The second thing, and Kacey, I'm curious what you think about this. Some of the studies that are looking at the environmental persistence are looking just for the RNA within the virus, and others are actually testing for a virus that can transmit the disease. Those are not the same thing. And so with the discernment there, just finding the RNA does not necessarily mean you had an infectious virus. So have to be cautious in that interpretation. And I'll just stop there.
Mary, you wanted to add something too, it sounded like.
Well, I just wanted to say that, given what Kacey and John have said, I think it's really important to err on the side of caution. That when we bring groceries into our house, we have a part of our countertop that's for dirty groceries and a part for clean. And so we let things sit there for days if that's something that we can do, or we wipe down groceries that have to go in the refrigerator, put them on the clean side, and then move them into the refrigerator. And we wear gloves when we have to go out anywhere, because we want to make sure that we're not inadvertently picking anything up. So I think erring on the side of caution is really good until we have more data available to us.
Kind of related to that, there's a very specific question about jogging, bike riding, outdoor activities. What's the advice that you'd share around that?
I've seen that study that's just come out of Belgium with the distance that needs to be taken. And I think, again, what's the point of not erring on the side of caution? I mean, really, when you know people who've had this illness and who've been really ill with it, it's really sobering. And I think it's very important to take those studies, even though they haven't been peer reviewed yet, into account. And I think that's another, I think it's important to remember that they haven't been peer reviewed, but there's no point in not keeping your distance when you're running or bike riding from someone else.
I think there's two things. There was a study from Belgium, and then there's been studies suggesting that there can be significant transmission through very, very fine aerosols and not just from droplets. And the aerosols can stay suspended in the air longer. So again, and there have been some instances, of case, clusters of people where the droplet, if it was spread by droplets, it doesn't explain everybody. And so again, it's that erring on the side of caution, and even outdoors, there is the possibility of spread if you're passing in the aerosol stream of somebody.
So kind of keeping on that thread a little bit, one of the questions asked about kind of the ethical responsibility of researchers, in wondering if we have an ethical responsibility to be in the field studying how the problem is affecting the environment. This is particularly for environmental researchers, I think. Or is it more ethical for us to stay at home? And I recognize that's a question every one of us is going to have to answer for ourselves. So maybe just from your own take, how would you answer that question?
Well, I'm going to start with saying that it's not even an option that we have right now. Our IRB has shut down all human contact research. So our only goal now is to stay at home.
And I would say that that's the same with my university as well. We're not allowed to do research we're not even allowed to do the research to go into our labs at this stage. So we are definitely under strict orders to maintain our at-home status.
Yeah, I think we're in the world of big data, existing data sets, and modeling.
Thanks. That's really helpful. Thank you. Mary, this question's especially for you. To build resilience conversations, it's essential to build connections among people. Do you have some good guidance for practices for talking to friends or relatives who have different points of view from your own? For example, that sustained close contact is needed for the disease to spread?
I think that it's very important, first of all, for us as scientists to model the type of behavior we'd like to see everyone practicing. When I walk out my door, I put my mask on. Even though I'm walking with my husband, I may not encounter other people. People can see that from their windows, from whatever, driving by in cars. And I think that that's the first step in making sure that people who are not scientists, people who are in the neighborhood, understand that we are taking these steps. We've had neighbors say, do you want to come over? And we've had to say, no, I'm sorry, no one's coming into our house and we're not going into anyone else's right now. So I think it's just talking to people on a person-to-person level and letting them know what the messages are that I've presented here that are being presented by our governments.
I think that even loops back to the question about ethical responsibility. You can't be, part of our responsibility as researchers is to sort of live the practices that we recommend and that our peers recommend.
And I think our governor in Colorado has done an excellent job of modeling that type of behavior. When he put out a recommendation that everyone wear a mask, he did so behind a mask. And I think he's continued to do that on a regular basis.
I'm going to shift directions just a little bit. With all of this isolation, and you've all sort of touched on this, so it's an opportunity to expand on it, but with all of this isolation comes a risk of some mental health impacts, especially if outdoor activity is limited. Any advice or recommendations you would give about how we can attend to mental health while also attending to physical health?
Right, I'll try to address this. I'm not a psychologist, but I think that we've seen some of the data coming out of China, and the Chinese have been very forthcoming in warning the rest of the world that this is something that really needs to be paid attention to, that they've seen some of the problems that have been, that they've had with the lockdown in Wuhan from a mental health perspective. And I think that one of the things we can do is ensure that we have a regular schedule in our days, that we try to get up at a certain time, do certain activities throughout the day on a regular basis, and also that we ensure that we stay in touch with people. It's really critical to do that, whether it's through Zoom or just phone calls, and make sure that that social network continues to thrive.
So I can't speak on an official basis, and although I will say I did hear that some specific guidance on psychological and behavioral aspects is likely to be coming out very shortly from HHS to help people, from a government point of view. But I just speak on a personal point of view on a couple things. The first is that, I think each of us is seeing both in the news feeds we look at, in the social media, that people are finding all the silver linings of the disruption and the fear and the despair, that there's this flip side of people refinding connections, as Mary said, not only maintaining social contacts, people are reaching out to people they haven't reached out in a while. And I think that one thing that people can do is just on a very personal level to be looking for those things that give them meaning in this time. We're not doing a lot of things that people thought were very important, and people are starting to reassess what really is important in terms of making them sane and happy in a stressful time. And I think there are a lot of lessons to be learned there. I'll just stop there.
Kacey, did you want to add anything?
I think just, one of the programs that seems to be sort of working here is, there's a lot of thought behind if you can reach out to somebody else, if it can help make you feel better. So one of the things that has been going on here is we actually have with our animal control shelter, people are reaching out and they are fostering pets. And especially for people who are alone, being able to have a companion during this time and being able to foster animals is one way that people have sort of sought some relief from being completely isolated, and that's one possibility, to reach out to your local animal shelter to see if that could be a possibility for you if you have the capacity to do that. And the other is to, just as Mary and John emphasized, really reach out to your network. Call that person that you haven't talked to since 5th grade and just see how they're doing and check in. And I actually had a surprise phone call from a friend I hadn't talked to in probably 5 years, and it was an unexpected pleasure to have the time to be able to sit and talk to them.
So we had a couple of questions about sort of recovery and what that looks like. I wonder, I guess I'll turn them into sort of two general questions. What are the kinds of larger lessons we can take from this experience? And how, when we start to recover, can we come back more prepared and more resilient for a broader range of disasters? The audience is asking great questions.
Okay, so I guess I will try to attempt to answer that, at least from one epidemiologist's point of view. And I think, some of the things that we can put in place are really some strong preparedness pieces that we actually have, a pretty solid preparedness plans in place for many of our local and state communities. Even prior to this, pandemic influenza exercises had been conducted, et cetera. So there are some things that are already in place. And I think being able to revise those plans based upon this lived experience, and to understand, what the signals are, to be able to have sort of a cohesive strategy for when there are these triggers. When do you actually decide that localities are going to start doing physical distancing and those kinds of things. I do also think that there's a real importance for better organization in the scientific community. So I think, what we've all seen as we've watched papers come out is there's a lot of people doing very similar work in different labs, and it would be really great to have some sort of system by which, we're able to really organize and share and sort of make our findings more efficient in a rapid amount of time. And I think with the preprints, this is something that has really come forward as being able to provide rapid feedback and scientific content, but there could be some other strategies to really organize ourselves in a way that we can efficiently provide knowledge during these swiftly moving outbreaks.
Great. Mary or John, do you want to weigh in?
I'll just echo some of that. We're seeing a couple of things happening that I think will have some lasting power. One is, in terms of platforms for scientists to come together and share information. We have one example, which is under the Group on Earth Observations. There are communities of practice. There's a very active now health community of practice, and this group has started meeting weekly and sharing information, and we have created, you know, cross-national collaborations between government scientists in Europe or government-funded scientists in Europe and academics in the United States. And I think that this kind of a model will, you know, in the short term anyway, stick in people's memories and be something that could be mobilized quickly. There are so many different dashboards that have been put together of ways of assembling information for decision makers. I think that thinking about how these kind of amalgamations and layering of geospatial data that are now being used in response, what, you know, we should be having a discussion when we are able about, you know, how do we do something similar for ongoing monitoring, surveillance, and early detection. This has been something that you know, we've been trying to raise attention to this from a vantage point of climate and health, the ecosystem disruption of climate change being a force that might you know, exacerbate or speed some of the emergence of infectious diseases. So how do we get the data collection? You know, I think if there's one thing that we've learned, you know, the one strongest lesson that I hope transmits into ongoing investment and action is that early information saves lives. Early information saves enormous economic disruption. So, you know, if we can translate that awareness that is so bitter and stinging in people right now into an ongoing investment into the right kinds of monitoring surveillance data, I think that'll be an important part of the recovery and you know, preventing the devastation of you know, of people and economies that we're seeing.
Thanks.
So I just want to add one more thing, Raj. And I think that this is the perfect opportunity for us to think along the lines of preparedness, that it's highly likely that we will see a second wave. We may have a lull here, and during that lull period is the opportunity for us to ensure that we're much more resilient when that second wave comes. So I'm hoping that we see that from the federal down to the very local level, that the hospital capacity is enhanced, that all the PPE is in place, and that we're ready next time.
So we are coming right up on the top of the hour. I want to thank all three of you for really informative and engaging presentations and for answering all these questions. I'd really like to thank everybody who tuned in for all of the great questions. I want to let folks know we have recorded this, and we are going to make that recording available along with, I hope, the slides, with your permission, on the Thriving Earth Exchange website, and people are welcome to link to it and share it. We hope this information gets out and gets out widely. Also want to invite anyone to get in touch with us at Thriving Earth if you have additional questions or comments or suggestions. And I guess just to wrap it up, I wonder if I could ask each of you to kind of, if there's any last thing you'd want to leave us with as we move forward. Not last ever, just last in the hour.
I'll be happy to go, and all I have to say is please stay at home.
Thank you, Mary.
And I would say, please curb misinformation that you hear. That's one active role that you can take as a scientist.
And the last is to be, you know, the messages that Mary gave about, and Kacey, you know, to be emotionally present, to be supportive, to maintain hope and maintain a positive attitude through, you know, this hard time. You become resources for your community, not just in terms of information, but in terms of well-being.
Thank you very much, everyone. Stay safe. Bye-bye.
Bye. Thanks, Raj.
Bye. Thank you.